Heather Landau from Memorial Sloan Kettering Cancer Center, and I'm delighted to present the initial safety and efficacy data from the NEXICART-2, the first U.S. trial of CAR-T cells in patients with relapsed and refractory AL amyloidosis. Based on claims data, it is estimated that 23,000 patients are living with or will develop relapsed or refractory AL amyloidosis, a diagnosis without a single FDA-approved drug. As this audience knows, that this is both a hematologic and organ disease and results in significant morbidity and mortality, particularly when the heart is involved. Daratumumab has transformed the treatment of this disease. This is an anti-CD38 antibody, and based on the Andromeda study, which showed a complete hematologic response of 60% when daratumumab is combined with chemotherapy in the upfront setting, this has become the single and only FDA drug available to date. However, 40% of our patients don't have an optimal response to initial therapy, and many others will also require additional therapy. And again, there's no FDA-approved drugs for second-line therapy. BCMA has emerged as a valuable target for plasma cell disorders, and NXC-201 is a unique chimeric antigen receptor T cell that targets BCMA. And this is a sterically optimized CAR-T construct based on three key modifications that decreases nonspecific activation, reduces cytokine release, and enhances plasma cell binding. And it can be manufactured in 10 days. And based on promising results from a trial that was done predominantly in multiple myeloma patients that allowed patients with AL amyloidosis, we designed the first CAR-T cell trial specifically for relapsed and refractory AL amyloidosis. This is the study design. Eligible patients had to receive at least one line of therapy, including a CD38 antibody and a proteasome inhibitor. They required measurable disease by standard criteria. We also allowed patients with a DFLC greater than 20, based on several lines of evidence that indicate that any patients with circulating amyloidogenic light chains above this value can have organ deterioration, and suppressing those light chains to a lower level result in better patient outcomes. In addition, patients who relapse often relapse with low burden of disease, and it is prudent to treat those patients before they develop organ deterioration. Patients who had prior BCMA-directed therapy, advanced cardiac involvement, or symptomatic myeloma were excluded. The primary outcome of the phase 1 was safety, and the phase 2 was complete hematologic response based on validated criteria. And we opened to accrual in June of 2024 and have completed the phase 1 with 10 patients being treated, 3 on the 150 million cell dose and 7 on 450 million cell dose without any DLTs, which allowed us to open the dose expansion phase of this protocol. And this part is ongoing with 25 more patients planned. Based on the data that's available as far as the data cutoff of April 11, 2025, that has been reviewed by an independent review committee, we are presenting the data on the first 10 patients. So the patient characteristics are shown here. The median age was 67, but we treated patients with an age up to 82. 4 was the median lines of therapy. 70% had had a prior autologous stem cell transplant. 70% of our patients had cardiac involvement, and although at diagnosis these patients had more significantly advanced cardiac disease, at enrollment you can see these patients had less advanced disease based on the fact that we treat patients before they develop progressive organ deterioration. We had one patient with advanced kidney disease. We were liberal in our criteria of allowing these patients with significant proteinuria and 2 others with more modest proteinuria. The safety data is shown here, and although the majority of our patients experienced cytokine release syndrome, it was mild and very manageable. It occurred early and was short-lived because we mandated that patients had received tocilizumab as soon as the onset was recognized. We did not observe any episodes of neurotoxicity, either ICANS or delayed neurotoxicity. Neutropenia was common, but there was only one event of febrile neutropenia, and this was not associated with an infection. Our one patient, not unexpectedly with advanced renal disease, did have worsening renal function shortly after CAR-T cell, and this patient became hemodialysis dependent during her CAR-T cell admission. However, she was discharged and actually doing well back to work and tolerating hemodialysis when later she came in with a septic event from her dialysis catheter and a subsequent infection, which led to her death at 5 months post CAR-T cell infusion. 2 other patients had grade 3 infections, but these were easily managed with IV antibiotics. And none of our patients experienced any unexpected or lasting cardiac toxicity. Here I show the results of the trial, and on the left you see a waterfall plot showing the percentage change in DFLC or M-spike from baseline, and you can see all patients' disease markers have normalized as of the data cutoff or the last follow-up, and the time to first response was 7 days, the median time. We did observe, like in many other CAR-T cell trials, that the immunofixation may persist for longer. On the right, I show a line graph of the prompt reduction in the paraprotein into the normal range, and this was associated with organ responses, including 2 out of 2 patients with cardiac evaluable disease and 2 out of 3 patients with renal evaluable disease responding between month 1 and month 4. Of course, there was renal progression in one patient, but no, we have not seen any patients with cardiac progression. We did have one patient who came into the trial with symptomatic cardiac disease, actually improved from NYHA class 2 to class 1 at day 15, and she was nice enough to share her experience, which I can show you here. She was very, never thought she would be feeling this strong and vibrant 15 days after her CAR-T cells, or experiencing less horrible leg fatigue, shortness of breath, and chest tightness that was increasing and weighing her down for the months preceding her treatment. And this just goes to show you that patients really symptomatically and significantly clinically benefit from this treatment. And here are the hematologic responses as reviewed by the independent review committee. You can see that 70% of patients to date have achieved a hematologic CR. The 3 patients who have yet to achieve a hematologic CR are MRD negative in the bone marrow at day 25, but remain immunofixation positive in the blood. There was, of course, one death unrelated to NXC-201 at 5 months following treatment, and no hematologic relapses or progressions to date. So in conclusion, in this patient population who have really a true unmet medical need, all patients receive treatment with a vein-to-vein time of 14 days. So this was done efficiently. Toxicity was mild and manageable, and we saw no neurotoxicity of any kind. All patients experienced rapid and deep hematologic responses with a median time to first and best response of 7 and 26 days. At day 25, 8 of 9 evaluable patients were MRD negative, leading to a 70% hematologic CR rate at this early time point, but we do expect that to evolve into more patients being in hematologic CR. Organ responses were documented in 4 out of 5 evaluable patients, and at a median follow-up of 121 days, we have not seen any patients relapse or progress. So this multi-center trial is ongoing and continuing to accrue to the expansion cohort. Thank you so much for your attention. Thank you to our research staff, clinical teams, apheresis units, therapy lab, cell therapy labs, and all the investigators at each participating site, and especially my team at MSK. It really takes a village to do these trials, and we are very grateful for the patients and the families who trust us with their care. And thank you for your attention.